Hi, everybody who is on virtual. We are just about to get started, probably about like 2 to 3 minutes. Just hang tight. Dr. Minichetti is getting ready and we will get started shortly. Wait, Dr. M, they have to unmute you. We can't hear you. Say okay. And then unmute.
Can you hear me now?
Perfect. And then Brianna, just pull up the PowerPoint again. It's like two inceptions seeing it like this. Thank you.
I know two inceptions. This is the one. You can give your intro though. This is
Okay.
Ryan's case. Do you want a mic?
No, can you guys, everybody hear me okay? Yeah, I'm coming across here, right? So welcome everybody to our first of the 2024 meetings, March. We're gonna have 4 this year. The dates were sent out in a previous email. Our agenda for this evening will be some business updates with the hospital and with our residency program. And then we're going to have a case presentation by one of our PGY1s, John Gattuso. And then we're going to have a speaker, Dr. Davis Thompson's going to speak about, sorry, I'm so sorry. We have Mr. Taub is going to speak about the all-on-X low denture procedures. That's our main speaker today. Sorry about that. So I'm reading different agenda. Okay. So welcome everybody. So a little update about our GPR program. Everything's going really well here at the hospital. Activity at the hospital has been very good. Our GPRs are much more involved now with Englewood Hospital inpatient care, or I should say same-day services, because we have a lot more cases going on within the past year or so than we have in the previous years. They're kind of like shaking their heads and like a great, good and bad, right? So it's good because you're getting much more hospital experience. Of course, it's bad because it takes you away from some clinical activities, but that is part of our GPR program. So we want to thank our residents for doing that. We're really like rocking and rolling with instruments and X-rays in the operating room. This stuff hasn't happened ever. So we've really come a long way with this hospital and dental care within the hospital itself. So I want to thank all the faculty members that have helped with that and my residents who have helped with that too. As well as the director of North Hudson. She is here today, Dr. Lavendier. Thank you for all your support and help with all these projects. So we do have a 3-year program on the 1-year option. This year, we're going to be searching outside the hospital for a chief of PGY2. So if anyone knows someone, we're going to start the interview process within the next month or 2. If anybody knows PGY2s, that's someone who's already completed PGY1 program, and they may be interested in becoming our PGY2 here at Englewood Hospital, please let me know. We're just posting it this week. We got the approval from the hospital to go outsource and approve that. So, and if anybody needs more information on that, please let me know. Couple of I think housekeeping things. Number one, with our outpatient care, thank you all of you attendings are on this call and all of you that are here for putting in all the time to help teach our residents. It's really a big commitment. I understand that, taking time from your personal lives or your even professional lives to spend time teaching. I hope it's as rewarding as it has been for me in the past. But some housekeeping that we're trying to get in shape. Our North Hudson recently had a joint commission from hospitals inspection. And so they were kind of like a little tiffed on a couple of things. I'm sorry, go ahead. Oh, it was an internal? Okay, it wasn't a formal. Okay, so it was an internal, sorry. So thank God. It was an internal one. Correct me if I'm wrong. Had a little inspection, and some of the things that they found were lacking. So I just want to kind of pick it up for the preceptors or our faculty who does go to the hospital, because some of them are a little confused on their duties. So And it's all written down in the classroom, so you guys have access to all this stuff anyways, if you ever do get confused on what your duties are. But some of them are, if I list them here, duties of preceptors, some of the major ones, responsible for overseeing patient care provided by the dental residents at the outpatient clinic, ensure that residents are charting in real time. That means by the end of the procedure. Infection control protocol, make sure it's being followed, going in and out of the room, washing your hands, wearing proper PPE, etc. Overseeing treatment plan diagnosis, and if you can get there and get them to do the morning huddles, it's a huge task. I like, where's the morning huddles? Which our PGY2 is supposedly going to be on top of, right? What are we doing today and what's up? What's going on? Like what's going on rather than just going for it. Overseeing diagnostics and treatment planning with the residents. And while not responsible for signing off on charts, you are responsible for making sure the residents do enter their entries, do their record keeping. Okay. Okay. So North Hudson is preparing for the Joint Commission site. So we wish to be more prepared. There is this Joint Commission preparedness packet, and it's in the classroom that you guys can read about. You don't have to memorize everything, but if you want to be a little bit more familiar with it, that's okay. Hopefully when this inspection or this site visit comes, we'll give you the update on who's going to be where. Just as a reminder, in the clinic or outpatient clinic, there's no opioids or narcotics that are prescribed. Everything is Tylenol or ibuprofen, prescription strength. So hopefully it's nothing more than they need that. I mean, that's the way we've been handling it. Okay, in the Englewood Hospital, we do have our block time now. I don't know how many of our attendings are on this call, but we have it blocked out for the dental department. There are a couple of pediatrics that are utilizing it, and it's really on the second and fourth Monday of each month from 7:30 in the morning till 12:30 in noon. So if we could utilize those times, that's good. And they may all be blocked up by now, to be honest, because the peds have been getting pretty busy, which is good. We do have the portable X-ray unit in the OR, and you can also take it bedside if the PGY1s needed it to diagnose someone in a bedside or on the floors. You could also take it to the emergency room, obviously, if you needed it there. Okay. The password for that computer that goes on that cart with the X-ray unit is actually pasted to the laptop cart. Okay. So yeah, I think that's probably all I have to say about the hospital residency program. We're pretty good with CODA. We had a live site visit. Nothing came up, and we're not due for another visit for, well, it's almost been 5 years since we started this, so it's going to be pretty soon, maybe about another 2 years. Can't believe 5 years is going to be our 5th class starting, so time flies. Yeah, I don't know if we've had a meeting since, but one of our past chiefs did pass. Dr. Mark Jaffe did pass. I don't know if we've met since that. Dr. Mark Jaffe was instrumental in, he was our chief of services here in the Department of Dentistry for probably a decade. So our hearts go out to him and his family. Our next meeting is scheduled for May 14th, and at that point we will have Dr. Davis Thompson speaking on addiction and substance use. So it's actually a good meeting because it fulfills the New Jersey state requirements on opioids. Mark Davis is one of the faculty members at Rutgers University. We have 2 other meetings, September 10th and September 19th. We don't have speakers booked for that yet. I'm working on that. If anybody is interested in referring or recommending a speaker, please let us know. And that's it. Okay, I have a little letter here. Let's see. Yep, yeah, we got the one. Okay, perfect. Yes. Excellent. Thank you. Yeah, just let me know. Perfect. Okay, so at this point, we are going to introduce our PGY1, so we get the night rolling. We have Dr. John Guttoso is going to speak on a case. Hopefully that's a familiar patient there, right? Yep. You're welcome. I'll turn it to Dr. John Gattuso. Yay! Woo! Good job. Let me get this out of here. I'm sorry? Need a power supply. Power supply. Nope. I'm just gonna look.
Right over here.
Just gonna come save the
Right
day.
over here.
Oh. The presenter one with the notes. I see my notes.
So if you do,
The presenter. Just wanted to see. I have notes, so I just wanted to see.
See if you just make it full screen. If you just want to begin it. And then if you click, there you go. Oh no, that's
No,
subtitles.
subtitles, and I think I just
hit X, it's like,
no subtitles.
if you go to slideshow,
Yeah, it should be right here, right?
set up slideshow. That's the one thing I don't know. My wife knows. That's the funny thing.
Just do it though. If you just put the slideshow again and then try from the beginning again because
Yeah.
if you click
You That was subtitles. Is it the other one?
Extra.
No, the next one.
no, I think it's this one.
Oh, presenter.
There you go.
Right up there.
There you go.
Oh, I should do that. I don't do that.
Yeah, so then you got, if you have notes, there you
Just
go.
like from memory.
Oh, no, on the Okay. No, she should be posted on the classroom. She said she put it up already. All right. Hello, everyone. Again, I'm John Gattuso. I'm one of the PGY1s here. So today I'll be presenting a case. Okay. So my patient was a 55-year-old Hispanic female from Englewood. She initially presented to our outpatient clinic, North Hudson, on January 18th of 2024 as a comprehensive consult. She was actually a friend of one of the assistants, and she was seeking new treatment, being at a private practice prior. She presented non-symptomatic, no pain. Her chief complaint was, I hate my smile, and I want front teeth. So this is Maria, and as you could see, she's missing a couple of teeth. So she wants to be fixed. That was her main point. So overall, we do a full workup at our outpatient clinic. So medical history, so she's on no medications, no known medical conditions, no known allergies. Her last visit to her primary physician was about 6 months ago. So I felt the need that there was no medical consult needed. She had no surgical history, so I classified her as an ASA 1. Social history, she is Spanish speaking, so she spoke very little English. So I'm practicing my Spanish as we speak. No recreational drug use, non-smoker, and just the occasional alcohol on the weekends. So dental history, so her last dental visit was at a local private practice sometime in September. She didn't have any previous FMX, so we ended up taking one as part of our comprehensive treatment. Her last prophy was in September of 2023 with that private practice. She had no history of periodontal disease. As I kind of got more and more discussing with her, I asked her how she lost some of those teeth. She did say back in her country she had them extracted. Wherever she was or whoever she did see, she said there was a lot of cavities and that she needed root canals, and instead of doing the root canals, they just extracted them. And then she also did have implants placed in site 3 and 5 at the local practice about a year ago. She is wearing a partial denture, as you could see. And then her aesthetic demands are high, being her front teeth. So this is a facial profile with the flipper and without. Okay. So
taking all of these photos, we kind of start doing a facial analysis. So symmetry was one of the biggest points that I wanted to start looking at. So where her midline lines up and how her smile aligns with the pupils of her eyes. Overall, her midline on her maxilla does line up with her facial midline, but her lower midline is shifted to her left about 2 to 3 millimeters. So when you take an intraoral photo, this is how she presents. So when you kind of look at her, you kind of start to see that her facial smile, there was a lot of things that are starting to be concerned. And then when you do the intraoral photo, it kind of gets worse. So one of the things I want to point out is she does have a zirconia bridge from 11 to 14. The bridge actually was loose and did have some open margins. And another thing that stands out is that number 5 implant and how facially angulated it is. These are occlusal shots. And you can appreciate, again, number 5 of how facial that is. And then also the implant placed in number 10 is also very palatal. And then on her lower, she does have a couple of PFM crowns across her lower arch, and she's missing some posterior teeth. And then we got some side views. Another thing here that you can notice is that due to the loss of her posterior teeth, she does have a fairly deep bite, and that most of her maxillary anterior teeth are flared facially. And then also the implant in site 6 is starting to have a mucogingival defect. I didn't take preliminary impressions. We did a scan with our scanner at the clinic, iTero. So these were just the digital models that I created. So taking a first look, intraoral exam. So she does have implants at site 3 and 5 and 6. She also has another implant at site 10. One of the biggest things that I mentioned before, number 5 implant had a big facial angulation. She does have a zirconia bridge 11 to 14, Pontics 12 and 13, and the bridge is loose. She's missing several teeth. I can list them. It's going from 3, 4, 5, 8, 10, 12, 13, 17, 18, 19, 30, 31, and 32. Soft tissue overall, she has physiological pigmentation, no edema, no swelling. Like I mentioned before, number 6 implant has a mucogingival defect. The good thing though, it wasn't implant threads that were showing, it's actually the metal collar of the abutment that's showing. And then overall, if I go back, as we can start to see in this photo, she has minimal attached gingiva. So you can actually can see how low she has a low frenum attachment in the anterior. That's pretty much at the crest of the ridge. And then even where the implant's placed at 3 and 5, there's no attached gingiva at all, and there's frenum attachment that's connected straight to the healing cap. Then overall, her VDO is collapsed. She does have a deep bite. Her occlusal scheme is compromised due to missing teeth. And then doing the intraoral exam, number 7 and 9 do have a grade 3 mobility due to primary trauma of occlusion. Flared anterior teeth, she does have an overjet of about 4 to 5 millimeters, and her oral cancer screening was negative. So we did a periodontal exam. Overall, no history of periodontitis. She was generalized gingival health on healthy periodontium. Her posterior teeth on her maxilla had 4 millimeter pockets, but overall, no calculated attachment loss. She did have a thin biotype. The biggest thing that I got out of the periodontal exam was the grade 3 mobility at 7 and 9, and then also her lower anteriors did have a grade 1 mobility. So this is her FMX. Going through, her FMX. As you can see, there's really not any bone loss or any periodontitis that we see. Overall, though, if you do look at the anteriors, you start to see some widening of the PDL. And then for the most part, her lowers, there's really anything wrong with the teeth. There's no radiolucencies or PAPs that we witness. I'll just go through the FMX. So starting with the upper right, number 2 does have a PFM. Number 3 is a Zimmer implant, TSV, 4-1 by 10. Number 4 is missing, and then number 5 is a Zimmer, also TSV, 4-1 by 13. And then due to the angulation of that was kind of a big questionable, how can we restore this implant, it being so facial? Could we do it screw retained? Could we do it cement? Do we have to bury it? Do we have to extract it? And that kind of started bringing up questions on how do we restore this. And then also going through number 6 was an implant. That implant actually is unknown. Still trying to find the make of it. I have the patient trying to figure out where she got it. She actually doesn't even remember where she got it. So we're still trying to figure that out. And then also, as you could see, number 7 does start to have widening of PDL. Number 9 also has widened PDL due to trauma. And then the previous root canal post and core is PFMs. Number 10 is a Neodent 3.75 by 13. And then number 11 is a previous RCT abutment. And then that tooth is an abutment tooth for the zirconia bridge that is loose. And then also, as you could see, the core that is placed has some radiolucencies and definitely needs to be replaced with a post and new core. Okay, number 12 is missing. They're both pontics on the zirconia bridge, and 13. Number 14 is the abutment with an occlusal composite. 15 has an occlusal amalgam, and 16 also has an occlusal composite. And then as for the lower, overall the lower is in good shape. Going through, there's several PFMs. From number 20 has a PFM, 23, 24, 25, and 26. And then 29 does have a previous RCT post and core. And then she's missing her first, second, and third molars on both sides. So what do we do? So as a new resident, this kind of shocked me. And I was like, how am I going to restore this patient? I've never done a full arch before like this. I've never kind of run into these problems. So that's when I seek help of attendings and then start to do research. And this is kind of what I came up with. So overall, due to her collapsed bite, we have to open her VDO. So we kind of predicted that we could probably open it up about 2 millimeters. And Dr. M said it best, get her in temps and see from there. So that's kind of where my head started to go at, is how do we restore these with this one facial angulation of this one implant. She's got implants all over in different, like not sitting on the arch in a proper way. So to properly see how to restore this case is to do a wax up and get her in temps and see where things lie. So that's kind of where I was going to start this case. So we planned her for a full arch milled PMMA temp using exocad design. Also, we were going to do a full digital workflow, even opening her VDO on a virtual articulator. And then in the meantime, also get her a lower partial to help with this collapsed bite and get her occlusion to be equalized. So overall, number 1 tooth is going to be extracted. Number 2 is going to be a zirconia crown. 3 to 5 will be an implant bridge. And then we're suspecting, due to the angulation of the bridge, that we're going to do it cement retained. Number 6, we'll do a single unit implant crown. And then based on how she has minimal attached gingiva, we will do connective tissue grafts in site 5 and 6. We will extract number 7 and 9 due to the poor prognosis and the grade 3 mobility. And we're going to place an immediate implant in site 7. And then we'll end up making 7 to 10 an implant bridge, screw retained. We are going to keep the teeth on her left side. We'll make it 11 to 14. We'll make a zirconia bridge. Number 15 will be a zirconia crown, and number 16 will be extracted. And then her final for her lower will be a lower RPD with acrylic acres clasps on 20 and 29 due to, we took a CBCT and she had minimal bone and she would need vertical augmentation if we even tried to get implants in those sites. So she is okay with doing an RPD on the bottom. So how we're going to sequence this case. So first off, when she presented in January, we're going to do data collection. Overall, we're going to do a prophy, oral hygiene instructions, get her an interim full mouth PMA temps, do a post and core on 11, lower RPD. We're going to extract 1 and 16, and then we're going to do a phase 1 reeval. And when we do that phase 1 reeval in her in temps, we're going to kind of see how we can restore this fully and make sure that number 5 angulation is okay and that everything aligns perfectly. Phase 2 will be the pre-prosthetic surgery. We'll do implant placement in 7 and 9, hoping to do an immediate implant in 7. We'll do soft tissue augmentation on site 5 and 6, and do a frenectomy to get some more attached gingiva in the anterior. And then phase 3 will be custom abutments for cement retained implant bridge 3 to 5. Final impression, we'll deliver crowns, deliver low RPD, and then occlusal guard, and then biggest thing is maintenance. Then it's her job to make sure that she maintains it and she comes on frequent visits. So my whole plan on this is to do this full digital workflow. So overall, I did some research based on how to do this fully digital using exocad and using a virtual articulator. So in this sense, it's kind of same thing you would do manually, but just virtual. So we ended up taking an iTero scan in CR, and then once she was in CR, we were able to then pull that onto exocad design and then open, pretty much like you would open a pin on a manual articulator. We did that virtually. And then we did some research that based on this method, the manual method of opening an articulator, opening the pin and doing it virtual, there's pretty much no significant difference in the accuracy of it. They're both the same. So this is the digital workflow of me using exocad to mill her PMMA temps. So we started taking the upper and lower scans and bringing them into exocad, as you see here. And then you virtually prep them just like you would, and you make temp shells. And then opening, this is what the virtual articulator looks like. Just looks like a regular articulator that we use manually. And it's been shown that higher accuracy of conventional approach based on conventional impressions, such as like pouring up a model, wax ups, there's just numerous potential for error, and that's kind of where the wave of digital dentistry is going. Less hands touching things, less errors, human error. So that's kind of why I wanted to do this virtually. And then the dynamic movements of a virtual articulator were shown to be as true or precise as a mechanical articulator. And then there was deviations, these deviations actually were less than 100 PMs, and then thus the deviations were not clinically relevant. And the results demonstrate that the accuracy of mounting techniques by Facebook record and average values can be clinically viable within an increase of vertical dimension of up to 6 millimeters. These findings are consistent with other studies, and that found that the vertical dimension increase by mechanical and virtual articulators should be limited to 5 to 6 millimeters. And as long as it's within that realm, it's precise. Okay. So this is the virtual wax up on exocad using their tooth library. And then once I got it to my liking and I was stopped trying to be a perfectionist doodling on this wax up, it was ready to print. And this was the result of the temp shell. And then now it's time to prep and temp. So this was the day we decided to prep and temper full arch. In order to temporize these implants, because they were Zimmer, we used the Zimmer copings that came with the implants and prep them as best we could to kind of angle the path of draw and make sure that everything would fit passively. And then I drew right here this line to show the arch form and kind of show where things lie. As we could see this, it's not sitting perfectly on the arch. 3 and 5 are a little more buckle. The number 10 Neodent implant is palatal. And then also this showed that 7 and 9 should be extracted because how far they are flared and they're kind of out of the arch. And these are the side views. And then we took the temp shell and we picked it up with just jet acrylic. So this is how she presented in January. And this is after temping her. So I think we're off to a pretty good start. So now she's ready for phase 1 reevaluation, kind of see if she likes her smiles. Do we like it? Are there things we want to change? How do things fall in the arch? Can we fully restore all of these implants and make sure that it's aesthetically looking? And then overall, this is the temps here. And then based on this, kind of just reassured everything I kind of went over in my treatment plan, that we are going to do 3 and 5 cement retained, and then keep everything else screw retained, and do as many individual bridges as we can instead of just doing full arch. So pretty much half our arch is implants, half our arch is going to be tooth borne. So now after this is phase 2 to get her ready for another implant. All right, we're going to place an implant in site 7. She's got more than enough bone, and we actually ended up placing implant in site 7 last week at Dr. M's surgical mini residency, and it went smooth. It went actually perfect. So she's back in temps. I relined everything and popped her back in temps. And then I just want to kind of go over, because we opened her VDO 2 millimeters, overall there's no TMD disorder. She's having no joint pain in her jaw. She's having no pain or anything like that, which is a good result, because I was doing a lot of research, and I know there's controversy on how far you could open someone. Should you even open someone? Are they going to have pain? And a lot of it was said, like, if the patient, as long as you're within, like, you don't go crazy with opening their VDO and you're within at least 5, like you don't go further than 5 to 6 millimeters, which we didn't even come close to. We only did 2. Most of, or if any symptoms of soreness or jaw pain would be self-limiting, and usually it would go away within like about a month. And they did say, a couple articles were saying how you should keep someone in temps for about 30 days, if anything. And if you feel that she's starting to have some soreness, you just have to keep seeing her as post-ops, adjusting her occlusion, and that you should wait about 6 to 7 weeks before you start to go to final. So I thought that was interesting. But so far she's been doing great. She's had no problems. She loves her temps. She thought they were the real ones. And I said, we have a long way to go until we get you to the finals. So to be continued.
Great job.
Thank you.
John, did you open her 1 millimeter at a time? Or
Yes.
two in one shot?
No, we did it 1 millimeter at a time.
And how long interval?
2 weeks. And then I've been seeing her we did this in probably about a month ago. So I've seen her about 3 times, and each time I've adjusted her occlusion just to make sure everything is okay. Because she came in probably about 2 weeks later, and she just felt that she was hitting some high spots. So I ended up adjusting her then, just the temps.
Be careful you don't bring her down.
Mm-hmm. Bring her back to normal.
Might I just, along the lines, suggest, the cases that I've done a long time ago, we did them 3 to 4 weeks, 1 millimeter at a time.
3 to 4 weeks.
It gave more time for the TMJ to reset.
Okay. Were you just like adding composite to the?
Well, yeah, just composite molars just to open it up.
Okay.
Because my concern is we said it in jest, but is that she'll keep saying just a little bit more, because the TMJ hasn't fully reset.
Mm-hmm.
And the longer she's in the opening, the more apt she is to adjust.
Okay. Awesome.
Can I take a picture of this?
Yeah, let's do it. Sure.
You stand over there.
Sure. Okay. We'll get one this way, get one with the group. Okay. Ready? Turn around.
Turn around.
So we don't block it.
Yeah, that's good. If you stand there, that's good. Okay, say cheese.
Cheese.
Got it. Thank
Good
you.
job. All right, great job. Thank you.
Well done, John.
Great job.
this one.
So yeah, thanks. That's a great job. And I believe Dr. Hong, you worked with him on that temporaries, right? Came out beautiful.
We increased her vertical 2 millimeters right off the bat. It's not like we gradually eased her into it, right? We didn't.
No, oh yeah, because we put her in temps.
Yes, so we didn't change the temps to gradually. We just kept her in the same temps that we increased her vertical 2 millimeters, right?
Yeah.
We just went to 2 millimeters.
Great. So, Jordan, are you set with your presentation here? Okay, cool.
Ready for the transition.
Okay, cool. All right, so thanks again. Okay, so let me introduce Jordan Taub. Jordan Taub is a vice president of Taub Products. He has 20 years of experience in cosmetic and implant dental industry. He specializes in the dental product development and marketing of problem-solving dental resins and new self-adhesive hard set cements. And his current focus is providing custom acrylics, high-strength cements, and technique solutions for full arch and denture industries for immediate low 3D high bridge dentures and final restorations. So I know tonight he'll be talking about full arch and resins and milling and stellar acrylic and et cetera. So I'll let him introduce all that, but please welcome and thank you for coming. Jordan
Thank you
Taub.
very much.
Pleasure. Pleasure.
It's a pleasure being here.
Thank you.
So again, my name is Jordan Taub. I couldn't have done that intro better. It was almost verbatim. I'm a third generation, I guess, dental family that's, born out of a lab back in the 1930s. So we have about 80 years of dental experience under our belts. And over the years, we've developed many different products that you've probably used. Back in the day, silanes, we were the first to market for silanes that help bond porcelain, and dye spacers. So a lot of schools would use dye spacers to, when you're building out a crown to take the place of your cement. So we've developed a lot of these products. And now we have products that work in the full arch space that are big problem solvers. So what I'm going to talk about here is some issues that we've seen over, I guess, the last 5 years that our Stellar has been out in the market. These are resin-based issues. They're not necessarily issues with scanning or finals or what zirconia, issues that have with zirconia, but more of resin-based issues that we've seen. And we have a solution to help with that. So I'm going to be talking about our Stellar DC acrylic, our Stellar attachment, Stellar glaze, and if there's time and you guys want to see it, I'll show you a short slide on our Larry's Magical Denture Elixirs, which gives a gingival stain to 3D printed dentures. Oh, this is fine. I'll just go this way. Oops. So one of the main issues that we've seen is patient bite. If the doctor doesn't do at intake, find out if they're a clencher or a bruxer, and they don't prescribe a night guard after this procedure, there's a lot of failures that happen. By giving a night guard, it readjusts the muscles, and then the bite has changed, so there's not a lot of force that's given. Otherwise, you're going to get fractured dentures right at the cylinder denture interface. So where our resin would meet and the wall of the milled or printed denture. Other issues can be the resin chemistry of the pickup material that you're using. So immediate load temporary dentures are made from milled or printed PMMA, which is polymethyl methacrylate. Current pickup resins are composite-based resins, BCDISG-based resins, or they're using cold cure methyl methacrylate monomers, the salt and pepper technique that you have. Those have issues, and I'll get into that in a little bit. The other issues that we see are surface preparation of the denture, if it's not freshened. So the surface may contain contaminants from milling oils, and if you've polished it, that does not help with the bonding. So we recommend fresh air abrasion or grinding before you're going to go do your pickup. Washing it and drying it makes sure that the surface is dry and clear of dust, and that will promote bonding chemically and mechanically. Composite pickup resin bond strength. Composite is not really compatible with PMMA. It requires a bonding agent for it to work. So if you've used other resins, I'm not going to name names here, but if you've used other resins, you have to use a bonding agent and there's maybe a failure. The failure is really at the bonding agent because you need that interface in order for the product to work properly. Bonds with these products can fracture during the 7 to 9 month healing phase, more so in the early end due to bruxing or clenching. Not to say that our product doesn't also fracture, but our product fractures at the interface. I'll get into that a little bit later on, but it fractures way later than other materials. So if company A's product is fracturing at 1 month, ours is fracturing at 4 to 5 months, and that has to do with the hold that our material has when a patient's really biting hard and clenching. So it's trying its hardest to hold on. Composite and cold cure acrylic have shrinkage, heat, and extended cure times. So the exothermic heat that's given off with curing is extreme with cold cure acrylic. Even composites get very, very warm to the touch, but with cold cure acrylic, you can get upwards of 140 degrees. So you risk damaging the patient tissue and bone structure that's there. Composite and cold cure acrylic have shrinkage that can cause tension when bonding to other materials. So when you're picking up your temp cylinders or your locators and that shrinks, then you're going to have misalignments and misfitting temp cylinders when you try to, reseat it. And you might have to go back and readjust or do another pickup. So again, it causes a misalignment and needing adjustment. They also have extremely long cure times, 4 to 7 minutes for self-cure composite. Salt and pepper acrylic is maybe 10 minutes plus. And then you have to either use water to cool the surface because it's going to be painful for that patient. This case shows that a patient bit on a hard object causing this fracture. If you look at the center image, you can see the arrow. It looks like a chip. I don't know what tooth that is. I just learned dentistry yesterday through YouTube. So I can't give you the numbers, but you can see that there was a fracture at that tooth. This caused a catastrophic failure of the denture itself, which was milled. A lot of milled dentures have very large holes, and the edge of the hole pushes right up against the edge of the tooth, and therefore causes a point of flex that is a weak point, so it can crack there. If you look in slide 1, what we think actually happened is this patient has piercings, and he was probably biting on the temporary, which then snapped. So while the denture was getting rebuilt at the lab, we talked to the doctor and said, why don't you give as many undercuts as possible, drill some holes in there, flood it with our stellar, slap it back on, which worked, and then held it till the repaired or the remanufactured the medial lobe denture was ready. So this was biting on the piercing. The next one is a fracture because of extreme clenching. I talked to the lab technician. This is a Bob Posey case, a Posey Dental Lab. He said that they had to build it narrow. So normally a denture is, I guess the recommended height of the milled denture is 13 millimeters. Anything less than that, then it starts getting flexible and could fracture. He was trying to push the limits. It was a very narrow lingual edge, as you can see, and it just couldn't hold the denture. So when this patient was biting, it was flexing and it cracked. The doctor did not have him in a night guard. So if there was a night guard, this would have probably gone all the way to completion, or it might have fractured way longer than it did. The next one is a push through. All the temp cylinders fractured, fracturing of the denture itself. This case was given to me by Dr. Christian Yates, and he was one of the first adopters of this product. He actually discovered the product about 5 years ago. Didn't know, he was looking for something that was better than the product that he was using. And I said, give it a shot. And he never looked back and has been using it ever since. This case, at the time, he was just keeping the denture cylinder walls as is, so he was just relying on sheer bond strength of our chemistry to hold it, and it pushed through. That being said about push through and fracture, it's not necessarily a bad thing that it happens. It's just how fast it happens. So when you have certain products where it's happening a month into the surgery, and it's a consistent issue, that's a bonding issue, bond strength issue of that product. Where our material will go is it waits till the last minute. So if a product is fracturing again at 1 month, ours might fracture at 5 months, and it's holding on as best it can. If it does go, we call it the airbag effect, and it's saving the implant site. It's saving the implant from damage and the bone structure itself, because that force is so tremendous that it could damage these areas. So we'd rather the fracture happen. Ours just happens at the last possible moment compared to other materials. So because of this case, I thought about how should the procedure go? How should these dentures be picked up properly without push through? And we came up with, or I came up with a case. It's the next slide. I'm sorry. But I came up with a solution to fixing that push through. This case is a rescue case by Robert Harrison at Harrison Dental Lab in California. It's a mess. So the doctor and the lab tech used the wrong MUAs, wrong height MUAs, wrong height temp cylinders. As you can see in slide 3, this was in the patient's mouth as is. They did not reline to try to hide those rough edges and the holes. And as you can see in slide 1 and 2, the gingival tissue kind of healed up around it. So it was very painful to get off. The material was, I don't even think it was our material. I think it was, I'm not going to say, but it was a competitor's product. It did hold. So this is not an issue with material, fracturing or pushing through, but more of just bad dentistry here. You can see that the vertical and horizontal alignment is off, and the lab technician had to pretty much redo the whole case. So these kinds of issues and failures result in angry patients, a frustrated doctor. That patient just bought a brand new BMW and it broke down, failed. Now the doctor has to go back and warranty it and fix these issues. And it's hours of repositioning, and that's hours of lost share time. It's thousands of dollars to the doctor that he now is not spending on other patients. So the solution that we came up with, which I was just discussing, is to modify the existing cylinder hole, roughen the inside surfaces with a coarse burr, give it a mechanical bite, cone and bevel the upper and lower edges, the intaglio surface of the cylinder hole. As you can see, let me see if this works. Is it? Oh, there. Oh, does it show on the? Oh, okay. Got it. Perfect. Much better. Okay, so as you can see here, if you bevel out the intaglio area, now you're not pushing a round cylinder through. The forces are now dispersed and becoming structure. It's now wider than the hole itself, and now the material will hold the denture in place. If the material is weak, yeah, it can fracture and push through. The material will fail. With Stellar, it has a mechanical retention to the temp cylinder, to the tie base. It grabs onto that onto the grooves, whether it be like a diamond hesh or horizontal slats. It grabs in there. It will not push through. It does not fail. By flowing the Stellar around the intaglio surface, now you're holding the denture in place. This also creates a larger area for chemical bonding and mechanical retention. So By doing this, there's less, we think, less ability for push through and fracture. That being said, a bruxer and a clencher are going to clench and do what they do best. So some of the favorable properties of Stellar is that it tack cures in 5 to 8 seconds. No other product does that. Light cures in 20 seconds. Self cures in 2.5 to 3 minutes. So if you don't have light, you don't have to worry. It's not as long a cure time. If you do have light, then you're going to tack it in place. You don't need to fill the temp cylinder hole all the way, just enough to grab. And once it's cured, it's locked in place. You go cylinder to cylinder, moving around, cure a little bit at a time. You don't need to flow it all the way in, because if you do that and you're going before you flow all the material into all the cylinder holes before you cure, it's going to kind of flow out. So just cure it a little bit and lock it into place. Backfill outside the lab, or outside at the lab time when the doctor is suturing and your surgical tech is cleaning up. That's when you fill the rest of the holes in, and it gives you the opportunity to clean blood off and re-prep the surface, and then you just use our material and finalize it. Our material has unnoticeable shrinkage, no tension after cure. So once picked up and you put it back down, it's a nice, easy, what's the word I'm looking for? Just a very natural fit. It doesn't, there's no tension on it whatsoever. There's no polymerization heat, which gives great patient comfort. It also has extremely rock hard durability. So if you add hot water right after you're done on the lab side, you put it in water for about 2 to 3 minutes, and that makes our material even denser. If you don't have hot water, it doesn't matter. It's still extremely strong. The patient's temperature inside the mouth will eventually, within the next few hours, make it just as durable as before by putting it in water. Compatible chemistry, it's a PMMA resin. It's got the same type of materials and resins that are in milled and 3D printed PMMA. There's no bonding agent needed, and it gives an extremely strong chemical bond to other to PMA dentures. The material to a milled PMMA denture is not as strong as the bond to 3D printed resins. Milled resins or milled dentures there's no double helix bond available. So it's very difficult to get a chemical bond to it. Ours does get a very good chemical bond, but it's not as strong as if it was going to 3D printed resin. That being said, it works perfectly throughout the 9 to 10 months max that this is going to be in the mouth, doing what it needs to do, which is holding a temporary in place till full healing is done and a final is put in. The material can be easily layered, and you just tack and cure, and it grinds and smooths easily. Easily layering makes it very good for doing verifications where you need to build it out over time. Colors come in pink and tooth white. Indications for this, again, are pickup and conversions of PMA dentures and MUA temp cylinders, pickup of overdentures and locators, hard relines, acting as support structure, creating implant verification jigs, eye jigs, and indexes, and I have a whole section of cases that I'll show different types of jig systems. Welding metal parts together, easily creating pickup impression copings and copings for PFMs. Pretty much anything that you can think of that maybe this would work, it probably will work. So case 1 is a chrome guided smile C2F. It's an FP3 case, which means that's the most bone reduction that is taken out, roughly 10 millimeters. Could be less, could be a little bit more. So there's a lot of gingival surface that's there. And the way that this system works is that they want to have small hole technology. So instead of having big cylinder holes, which you'll see in some of the other cases, it uses, if you look at the lower slide right here, it's kind of sealed. And what they do is they pick it up and then they drill through, and it's just a small hole that's there. And what the reasoning to doing this is that there's no chance of fracture because there's more material that's there to hold it in place. They take a verification, that's the first one. They then pick it up in the model here. And then once the analogs are placed in the model and picked up, then they build the denture that's going in the mouth on it. And you can see that in the last slide here. So they'll inject our material into these small, tiny holes that are there and then pick it up. And then there's no big hole that can be a point of fracture. This case is a Smileology and Thomas Kuhn case. Thomas Kuhn is a very well-known surgical technician. He's probably got 10,000 plus cases on his belt. He essentially does the surgeries for these doctors that have no idea what they're doing, and he'll go in there and have just amazing results. So I believe this case was an FP1. It went sideways and they had to make it an FP3 or something like that. They had to use our material to bond the teeth and build the gingival surface. So the whole gingival surface here is our stellar holding it together. This is a very interesting case. So Robert Harrison, he's the gentleman that you saw with the rescue case with the temp cylinders that were the wrong length. He had a case with a severe mandibular bone loss. They were going to try to pick it up. If that failed, then they were going to do a bone graft, suture the doctor back up, and rebuild. It's crazy. It worked, though, right? They're like, let's see how far we can push it. So you can see it's barely picked up. Yeah, you can see that it's barely picked up. In slide 2, it's not even fully encompassed. So the temp cylinder is exposed on like a quarter of it is exposed, and there's a lot of blood. It's still picked up. It was still a passive fit. That was the word that I was looking for before, passive fit. And when they built it up, they built it out, they cleaned up the blood, and then they built it out of stellar. And then once it was built structurally with stellar, then they put cold cure acrylic over it to add mass to it. And the patient went home with this. And that's all I know. I was supposed to get some more slides about it, but I haven't yet. But it's a very interesting case. This is a Strawman Smile in the Box FP3 case. It's a pinned system. So some guided surgical systems are pinned, and then you unpin and you put the next prosthesis in that's going to do the next procedure by pinning it into place. Some systems are stackable, and I'll show you the stackable guide system. This is not one of them, but the first slide is it's a guide for drilling the holes for the pins. The second slide is the bone reduction guide that's in there, and about 10 millimeters come off. So the skin, the tissue is flayed back and sutured back into place, and then all that bone is coming off underneath here. The next guide is pinned in. That's the osteotomy guide, which gives you the depth of the implants, the angulation, and also where you're torquing to make sure that the MUAs are in the right position. And a lot of cases that I've seen, sometimes they're not torqued into the right position, and you have MUAs kind of doing funky angles. Last slide is just rubber dams that are put there just before the the denture is picked up, and that just keeps our material or any other resin out from the bone. Here it is picked up, bloody environment. It was a very successful case, and this was done by James Angeloni, known as the Denture Man. The next case is Absolute's. So Absolute Lab has shared technology with Rose Chrome Guided Smile System. This is their version of it. Came out after Chrome. This is their navigation system. This is an FP2 case. You can see that it's a stackable system. Everything is pinned in and then picked up. What I recommend, and some doctors don't do this, but if you look here, you have red and blue plugs. And that's very important to put in so you don't get pickup resin in that cylinder hole, because you can grind it out, but it's very difficult. Those are very long. And if you get material in there, you might, the screw is very small, you might not be able to get it out. And I've had people tell me that they've had to cut the denture off and start over, which is not a fun thing to do. Here you can see in slide 1 that it's not fully filled in. So the doctor grabbed just enough to get it cured, and then is going to backfill. He's going to clean all the blood off, and they'll backfill lab side. So this is Dr. Christian Yaste out of Ballantyne Dentistry down in Ballantyne near Charlotte, North Carolina. And the person that's doing the technical work is Jackie Krinick, who's his surgical assistant for many years. So once they do the backfilling and she's happy with how the result is, they'll grind it down and send the patient on their way. So this is the end result. So this is what I'm talking about, very wide cylinder holes. The the C2F case that I showed, the first one, doesn't have those holes. It just has a hole that's wide enough for the driver to go in. So that's the difference there. The next case is a case with Bob Posey, Posey Dental Lab, and Dr. X, who I can't name. This is a double arch. This was Dr. X's first double arch case using chrome, and it was a bear. You can see the bone reduction guide. So once placed, those teeth are coming out. They'll shave the bone down. Second slide is the osteotomy guide. Third is shows the carrier guide, and this carrier guide, this is the stackable guide system. This carrier guide will show the positioning of where the MUA needs to be in order to be in the right angulation. It also holds the denture in place. There's 2 pegs that stick up on this system. It holds it in there. You just hold it with one hand, inject, as you can see in the last slide here. Here's his hand. He holds it. All he has to do is pick up one cylinder, light cure it, and then it's hands off, and you fill as you want, when you want. So just enough, and then you go back and backfill. So here's the material being picked up. The white material in here, there'll be more better slide of it. That's our liquid magic, but you can use those pegs in order to block it also. It's being cured. You can see this was an extremely bloody environment, but it got a good pickup. Here's the lower being done. Liquid magic being injected into the temp cylinder and the denture being picked up. This is a happy patient right afterwards. So I wanted to discuss, I have a few different cases that are jig based for verification. This is a very old technique. This is the floss technique. This was done by Dr. Adam Kimowitz. And he just extruded out our stellar over the floss, curing along the way. So it didn't drip and it held. And you just cure it over the analogs. And then once he unscrewed it, it was a passive fit again. He just picked it up with PVS material, and that becomes your pickup impression coping. The next case is a multi-part 3D printed jig system, similar to iJig. If you've ever seen iJig, this is pretty much how it is, but this is Absolute's version of it. It has dovetail locks based in to give more mechanical retention, so it's not just a chemical retention. The way that this is filled, I don't know if you can see, there's a hole here, and there's holes at each interface here and here around, and you just stick the syringe in there and inject it with stellar or other material, and then it flows into the gaps and will chemical cure to it. The next type of verification system is grammetry from Rowe. It uses OptiSplint technology. OptiSplint is used in a couple different types of companies. I believe Digital Dental Craftsman has their own version of it. So grammetry, without getting fully into it, because I don't know all of it, comes with different analogs that will attach to or scan bodies that will attach to the implants, and you're going to use a scanner to get the proper measurements. You use our Stellar to attach the frames that you can see here. I don't know if you can see my cursor here, but these are the two frames, and they will be attached with our product to these OptiSplints. And what Rowe has, this is scanned, but there's, I believe, with grammetry, they take 3 different types of scans, which other companies don't do. So they're combining all these different scans to give the best picture available, best verification. So here it is picked up with our Stellar. You can either use pink or white. White sometimes shows up better, but in the, I guess using the iTero scan from Dentsply, it was showing up perfectly. So this is the case. Sorry, I think this was a CEREC scanner. As you can see, the material is being picked up very nicely. There's no major artifacts. And that gives a very accurate verification. The next type of system is the bar system. There's a company out of Europe that makes something similar to this. This is a prototype from Daniel Nowak. It's his version of it where I guess normally the bars just have like round holes, and this is ovaled out, which allows you to use multiple sizes instead of just one specific bar for a specific type. You can mix and match it a little bit better. It'll seat a little better. So you have these yellow stoppers that hold everything in place, and then you use our material to pick it up. This is actually a prototype light cure only Stellar that's not on the market yet. He's testing for us. Once picked up, then you do a stone model. So you get an accurate verification jig that you can scan, but then you have a stone analog master model, which some people like more. They think that that's a better representation than just going fully digital. So this is his version of it. It's not on the market yet. The last case is an interesting case. This is an acrylic partial that failed one of my friends who's not a dentist. He's a welder, and he had a banquet that he had to go to. So his doctor fixed this 3 times, and 3 times it failed. And he calls me up, and I've known him for years. And he calls me and says, Jordan, I know you have some stuff. Like, what stuff do you have? And I'm like, I got the stuff. And I'm like, you need, an LED flash, an intense LED flashlight and a Dremel, and we'll get you going here. And I sent them up some Stellar, and I told him, you can see the fracture here. This was the repair from the doctor. This was the 3rd repair. The doctor couldn't get it done until later that week, but he had his banquet on the Saturday. So you can see this is his workbench, and he was able to do the repair. I told him to drill down, roughen the surfaces that you're going to bond on, take out the metal bars that are there, and if they're smooth, put grooves into them, hex grooves, whatever you need to do, so you'll get some retention. Also, I-beam out the area that the metal bars are going to go into, so you're getting horizontal and vertical integration of Stellar into that partial, and that's what he did. This is the 4th. You can see right here It's a little, this is where he ground down. He could have probably flowed some stellar down a little bit just to make it look nice, but that's inside the mouth. He didn't care. It really had to do with like he wanted some front teeth when he went to talk to people. So for all intents and purposes, this was a success. And this is what he actually builds. And these are full-on race bikes for downhill stuff where you see people, the Red Bull Rampage, jumping off 100-foot cliffs. That's the bikes that they use. And this is what he kind of does. So here's a couple long-term reviews.
Here's a good case, first one of the year.
It's James Angeloni.
Stellar material, not the pink, but the white. And this case was actually picked up around 5 months ago. First time it came out of the patient's mouth was today. And you can see we had 0 D-lambs on the Stellar product. Everything adhered really well, and no bonding issues, no cracks, no nothing. So definitely highly recommending the Stellar from Taub products. All right, here we go, another Pro Arch. This patient was actually seen November 9th, and the pickup material,
2 years prior.
Material that I used was the Taub A2 color. And if you look really closely, we have 0 D-lambs, 0 fractures. Everything was intact. We had no leakage. Everything looks really, really nice. I did relining with this material also on that side, and that actually held up really nice. So Dentrman definitely recommends the Taub, the Stellar. And if you'd like to see more, I am lecturing at Midwinter and Lab Days. So go ahead and look me up if you want to see how I use the product.
The next product is our Stellar attachment. Essentially exactly the same as the regular Stellar. The difference is the self-care time. We made this one a little bit longer to play with. So 3 minutes of work time versus 1 minute of work time. This will allow you to do 4 plus locators at a time if you want to do it quickly. Fully set in 5 minutes. The same unnoticeable shrinkage, no polymerization heat, passive fit, same rock hard durability as the original Stellar. Same compatibility to PMMA, no bonding agent needed, chemical bonds to the PMMA dentures. We recommend roughening the bonding surface, hogging the hole out to give more surface area for chemical adhesion and mechanical retention. If you press fit your locator in there, then you're only getting material around the inner groove of the locator, and then there's metal to unbondable denture that's left. So by hogging that hole out, you're allowing our material to act as an in-between, fully encompassing the locator itself. So indications are for multiple unit pickups of overdentures anywhere that you need more time to work. Comes in pink shade only. And one case here. So this is a Zest locator case by Joseph Massad. He and I developed this product. You can see in slide 1 that the holes have been hogged out. Here's slide 2 of him injecting Stellar, placing the denture, and then after it's cured, popping it off and finalizing. And here's a video of that procedure. To get it out. He had one that didn't come out one time.
Yeah.
He said he forgot to put the block out ring in. Whoops. The next product is our Stellar Glaze, which is an overcoat over these dentures. PMMA is porous. Stellar is less porous, but still porous. So if you want to add a shine to it, you will apply this over the full surface. I recommend doing all grinding for occlusion first, then applying it on there. Otherwise, if you put this on first and then do your grinding, it's like taking it right off on the occlusal surface. So this is great where, let's say, there was a pickup and there was some blood. So at the interface between the denture and our material or another person's material, There's just a fine micro, I guess not fracture, just a micro gap. Putting this over the surface will fill that in, and then you won't get any, organic material in there. Light cures in less than 30 seconds, no bonding agent needed. This material has a wavelength of 475, so you need a curing unit, a dual cure, or what's the other one? I think there's a Dentsply version also, but you need to have a curing unit that will be able to cure at the higher wavelength of blue light. Majority of printing resins are on the lower wavelength 385, and those light boxes will not cure stellar or the stellar glaze. So you just need to be mindful of that and look at the DFU. So sealing porous PMMA fills and seals the micro gaps on the chairside conversions. Compatible with PMMA acrylic, milled PMMA, Lucitone 199, 3D printed resins, Flexera, Onyx. Let's see, what are some other ones? Forgot. Milled Peak, Trinia, composite, and titanium. And that's all. Any questions on the seller line?
Any questions, docs? I guess you work with a.
Oh yeah, I have one more. It's like 2 minutes.
Yeah, go ahead. How many labs do you work with?
Probably like over 100 labs. Probably like 4,000 doctors right now. We're doing 20,000 syringes a year with this product, so that's about 25,000 cases, give or take. Let's see.
Will you speak about the liquid magic?
Sure. Let me just show you this other one here. There it is. And then I'll talk about liquid magic a little bit. Okay, so this one is called Larry's Magical Denture Elixirs. It's meant for try-ins and short-term temps. So anywhere's 1 to like 6 months, 7 months. Any longer, and you might get some chipping. You might have to come back and fix it up. So this is an amazing 20-second air dry, Tauba colored gingival stain adventure from printed and milled PMMA dentures. You can do the case that is shown here by Daniel Soma in 10 minutes or less. Normal cases with composites can take about an hour. Using OptiGlaze can take about an hour because you have to cure it for each step of the way, 5 minutes. This is a very quick way. 3 coats gets you that color. It works on Onyx, Rodin, Flexera, any of the printing resins, milled materials it works well with. There are procedures that you need to do in order to get a longer bond, but it's perfectly matched to Lucitone 199 denture shades. So we have light pink, light reddish pink, an original pink, and a dark Mahari. We use this for full contour try-ins, immediate load PMMA temps, PMMA bridges, gingival staining for shades A0 through BL3, 3D printing resins and milled PMMA, and this again replaced the costly composites for the short-term denture. You can see here, this is a case by Daniel Soma. This is using our number 4. So this is just 3 coats, but it depends on where he's placing it. So more coats here to give a more intense color. This is showing kind of like a bleaching effect. Two different sizes are available. The 12 ml size will do about 15 to 25 arches, but it's dependent on surface area. The smaller 6 ml size will do about 10 to 15. Here's 3 coats of Elixir, number 13, used along with OptiGlaze on a next dent bleach shade. Here's our number 4, our number 1, so you can see the differences in color. I mean, obviously each photo that comes in is is not color matched, but it's close enough to show you the differences. This case by Miguel Casañas is using Nextent resin. He's light curing it because he put a light cure glaze over the surface to lock it in. This case is done by Dr. Wally Renee. I'm not certain if any of you have heard of him. He owns the Mod Institute. He's on a couple of the forums on Facebook, and he did this novel airbrush technique. Looked good, looks great. In practice, absolute waste of material. So he's getting per bottle, or was getting per bottle, like 4 cases, if that. It just aerosoled everything. It looks great, but it just evaporated. So novel case, but not, I wouldn't recommend doing it this way. And here you can see a custom shade, number 4 with number 10 striations, and then number 10 at the bottom, the Mahari color. So you can see the purples. And that's it. Yes, okay. What's the question you have on liquid magic?
Yeah, so how do you use it? Do you have any slides on liquid
I
magic?
don't, unfortunately. Actually, I do. Hold on. We'll just go quickly back to the other. Okay. Here we go. So originally developed for replacing Teflon tape and a cotton pellet down the axis hole on a single tooth abutment. Cotton pellet holds organic material, holds the saliva, it gets real stinky, and this does not. So you can inject our material. It's got a 3.5 millimeter depth of cure, and you can inject it down, touching the screw head. It will come out, and even if it's liquid, it's not going to act as a lubricant to take that screw head out. It'll just sit there. So if you don't cure it fully, because abutments are sometimes longer than 3.5, and maybe you didn't cure it in stages, but it plucks out completely clean. And yeah, it's kind of like ferment. It just doesn't disintegrate. Yeah, it feels like that. Yeah. Yeah. You just go around the rim and then it plucks right out.
It's comparable to, you might be familiar with glue. It's the same idea. It's like a BPS. I've used it to block out undercuts. I've used it to create a passive wedge through the mylar strip. If you put a wedge in, you spend 10 minutes stopping the bleed. So if you just overlay the mylar, squirt this in.
Let me see if.
How is it comparable to like paint on rubber dam? Is it flow?
You can flow it and use it as a rubber dam material. Yeah. Yeah, unfortunately, I don't have, this isn't the right case to show. But you can see here on the abutment axis hole, it's been filled in. I just don't have, actually right here, you're just flowing it in and curing it in place. You just want to make sure that it's not bubbling up over the abutment, because then the implant won't seat properly. So it needs to be flush.
So basically, once you put it in, periopropylene and periopropylene explore, just in and out a couple of times, get the air out of it. You'll actually watch it sink down a little bit because of that. And then I put a regular drop on top of it. The trick is not to go over the edge of the screw.
And it's easy to remove.
Yes.
Very easy.
Yep. Oops.
No drilling.
It's too far. Doesn't want to work for me. Okay. So yeah, you just inject. When you're doing these types of cases, then you're not injecting it all the way down. You're just putting a little dollop at the top. It's just to block the temp cylinder hole from getting resin in there. But it's a very easy product to use. I don't recommend using it as the cap on a denture that's going back with the patient. Number one, it'll fall out. Number two, there's not a great flavor that comes with it. Some doctors use it and just say that this is what it is. That's what they tell the patient, send them home with it, but I don't recommend it using for final. We have a material we haven't launched yet, but it would act as like a composite over that material. And that's it. Any other questions? Thank you.
Thank you.
Oh, that'd be nice.
Yeah, that'd be funny.
It matches your.
Taub in front of Taub. Oh my God.
And get the belt buckle.
You guys are awesome. Let's get a picture with everybody too. I mean, it's a small group. Let's get a picture. Can we get a picture? Yeah, let's get a front. By the sign?
If you guys want to go, if you want to say bye and then on the way out, if that makes you feel better, you want to connect in.
Well, let's get a picture right now before I leave.
All right.
They go restroom, they're gone. We've got the whole day.
Did a nice job.
It's gonna die with me.
Yeah, I can see.
Cheese.
Awesome.
Thank you again.
I feel like you always do.
So how's it going? Yeah, you like it up there?
Yeah, really good. Commute's not so bad. Yeah. I mean, every so often I'm really tired at the end of the day. So we are moving to
Great places I want to go.
yeah.
Good case.
It'll cut my commute. It's been really good. I'm happy. Yeah, very, very busy. Yeah.
You run it.
It's great. We do like all same day. It's great. It's a lot of digital. I don't know how it's been now with the iTero.
Yes. We don't.
Yes.
Yeah. We're not doing too much content with it, but we are taking a lot of demos. Yeah. The Crown Bridge stuff. I think it's still easy. Just with the iTero. With specific stuff.
I don't know who you
I mean, it should be
still work
basic
with.
stuff.
Yeah.
It's great. Basic stuff is good.
Because like, then he has to send it out. That's
Yeah.
why it's like easier.
So,
Because he does those.
Oh, okay.
Yeah, the splash. That's cool.
Ties, baby, cones.
I like what they do.
Where are you headed to next year?
Not really.
So you can just go into wherever you thought.
Justin.
Oh, really? That's so awesome.
He's still waiting for his credentials.
That is so awesome.
I actually applied for
Yeah.
just because it's like right
I
there.
still have everything in my
Yeah, I keep going on that. I'm sorry, but I used to live there, it was Massachusetts. I inactivated, but I kept reworking New Jersey. Because I went to Tufts, so I'm still working. But you get the licenses at the beginning because
Good.
it's
Actually very different.
There's a lot of differences. Like the crazy thing about the new ones, like you need a GPR.
Now.
It's crazy.
Yeah. I didn't put mine. That's what I'm saying, whatever you do, like now. All I did
Before
was
laws
scratch
change.
it. Before the laws change, yeah.
Do you guys have a lab?
Justin's coming.
It should be, I don't know when he's
How
gonna
many
start.
is he gonna be there on the same day?
I don't know yet. I don't know, 'cause they have multiple.
Oh. Is it, what kind of?
Sorry, I'm moving horses. Yeah, but like, but smaller, I guess.
So, yeah.
So a little more, I guess.
Yeah, that's great.
Like I know all the doctors.
Yes.
Like, you know, viruses. Which is a lot, but I'm not talking like.
Yeah.
So.
Yeah.
He wasn't happy
My
as hell.
friend from dental school, he's in the Max just quit hospital. So he said he would see like 30, 40 patients a day. 30, 40 patients a day.
He's now doing all the.
Yeah.
New products.
It's a great day